sleeping.
All right, everybody, we're gonna get started. We have Janine visiting us here from Cleveland, the, UBC, Ottawa, and she's done one, not just one, but two, completing two fellowships in epilepsy and movement disorders. She's gonna talk to us today about some surgical strategies for opercular epilepsy.
Thank you so much, Dr. Cove. Thanks, everyone. Thank you to Dr. Ellen Logan and Dr. Grannon for and also inviting me to present at your grand rounds. So I'm noticing that I'm going to use this as my pointer. This one.
Perfect.
Is that good?
Yeah.
Perfect.
Perfect.
So I'm going to talk to you today about Operculum and surgical strategies. I'll go through some cases and then some research that I'm doing currently as an epilepsy neurosurgery fellow at Cleveland Clinic. I've titled my talk Beyond the Operculum, Tractography-Informed Surgical Strategies and Emerging Frontiers in Opercular Epilepsy Management. And I think that is a title that envelops everything I'll talk about. And then at the end, I'll talk about some other interests I have. Currently, like Dr. Ko said, epilepsy neurosurgery fellow at Cleveland Clinic. And last year I did my functional neurosurgery fellowship also at Cleveland Clinic. Yeah, I'll do this one. So I don't have any conflicts of interest. My background, I'm Canadian. I grew up in Victoria, British Columbia, close to here. Glad to be back today. I did my undergraduate in Montreal at McGill and UBC, University of British Columbia, for my medical school, and then Ottawa, our nation's capital, for neurosurgical residency, and then close to completing my fellowship now at Cleveland Clinic. So my contents, I'm going to talk about a very, very brief opercular epilepsy introduction. And I really want to dive into the case-based examples, because I think that's a good way for us just to cover general anatomy and cover kind of our epilepsy workup and all the way up to surgical strategies and the surgical approach. And I want to just emphasize the surgery part because we can get really deep into each of the cases of the pre-op workup. So I want to just make the focus on anatomy and surgery. So I'll do two cases that I think covers most of the operculum, one dominant case, one non-dominant case, interesting in different ways. And then next I'll talk to you about my current research, which is on tractography-based post-op outcomes. And then I'll talk about some work that I also do in thalamic neuromodulation in epilepsy. And then I'll talk about future directions. Before I end, I'll talk about some of my other interests that's unrelated to tractography epilepsy, and that's post-stroke neuromodulation and focused ultrasound. And then I'll end with some of my personal objectives, as well as some thank yous. So brief introduction, opercular insular epilepsies are not super common, 1 to 2% of focal epilepsies. But I think that underestimates the true numbers just because there's a diagnostic gap. Scalp EEGs, it's hard to access in particular patients. So it's easy to miss sometimes. And then also semiological mimicry. As you'll see with one of our cases, it can happen in opercular insular areas. The epileptogenic network, it just spreads and it mimics some other diseases. So it can be difficult to diagnose to start off with. And then furthermore, the SEG axis, we like to put our electrodes mostly orthogonal, and you can imagine all the vessels in this area. So it can be tough to get accurate SEEG placement where we want it to go due to the vessels that obstruct our way. So I want to just jump into my cases. There's going to be these two cases, and these cases are from a recent publication that we wrote up in on surgical approaches to the operculum. First case, so this is, I'll just tell you right off the bat, this is a dominant frontoparietal opercular epilepsy. We'll focus on the surgery. But essentially it's a right-handed male, drug-resistant epilepsy. His semiology, dialectic spells, changes in facial expression, perioral twitching, and then also expressive speech difficulties. So you can already kind of think in your mind, we're talking about this periolandic area seizure network. maybe dominant because of speech difficulties. And in fact, our EEG shows left central epilepsy. In A, you can see it's non-lesional essentially. I just have that one slide, but I'll tell you it's a non-lesional case. B, PET shows similar area, this frontal parietal operculum hypometabolism. And then C, which is our MAG, you can see clustered MAG dipoles in the same area. And so at this point, you're thinking, well, it's very concordant so far. EEG, semiology, MRI shows nothing, but the PET and MAG, everything is concordant to this left frontal parietal area, left frontal parietal opercular area. But then the next step really is to think about how are we going to approach this if we want to do this surgically. And I think SEEG is a good way for us to really pinpoint where we want to go if we want to do this surgically. And so that's exactly what we did. Hopefully you can see the dots there on D. So these circles, these signify our SEEGs. This is our map. You can see that we centered our SEEG like inferior frontal, parietal, operculum, and then some other frontal, just kind of to capture the entire seizure network. And then D is showing in blue are just the silent SEEG electrodes. And then this one here, yellow, is the interictals we captured. And then the spread is actually to this green frontal pole, temporal pole spread of the epilepsy. And so this is all kind of making sense so far based on what we have, information that we have. And then in E, after we stimulate, that's signified by the electric, so this like lightning bolt. You can see in red is the epileptiform activity. And that actually is centered around this like motor, this is motor sensory, S2, opercularis. And so this is highly eloquent area, of course. And then I wanted to also show you our SEG in these two red SEG electrodes that are active, how it looks on our coronal, because I wanted to show you that actually the deepest part of our electrode silent, that's the insular contacts, and then more proximal are opercular contacts active with epileptiform activity. And so I think that's an important point to just distinguish that is there insular involvement, is this operculum? And we decided with our SEEG that this is really an opercular specific focus of epilepsy. I think at this point, we wanted to also just look at our surgical plan. And what we did was what we like to do is incorporate tractography. We using BrainLab, and so the convention is actually DBS convention on my template that I use. So cortical spinal tract, you can see that our area of focus where we are looking at where the seizure is starting and the network spread is really close to both cortical spinal tract. And in fact, we were in motor when we looked at that. We're just behind motor, close to motor sensory face, just below where we are starting the seizure spread. And then also arcuate fasciculus, you saw that inferior frontal opercularis area, and that was also active. And so really we're talking about like a dominant, very eloquent area. And then pertinent tracts to think about in these cases, speech tracts, cortical spinal tract, SLF3, deeper arcuate fasciculus. And then I wanted to also just pause here, just given what we know would, who in here would do this case an awake case? And then who would put a subdural grid and then close and then map and then come back and do this asleep? Yeah, and then who would map based on the SEG? Using the SEG to map like language motor?
Would try to.
Would try to, yeah. I think I think determining someone awake or asleep cases, it can be difficult sometimes. I mean, sometimes you have the obvious, like they're not going to be able to tolerate awake. Other times you think they're going to be okay, but then you get in there and there's like things go wrong, they can't wake up. There's some things that could happen in the OR when you try to wake them up and it doesn't work very well. And so I think it's good to have in the back pocket to put the subdural grid, like talk about it in your consent. Like if we can't wake you up, we would put a grid and then we would map you and then potentially come back. But of course, that's only the cortical mapping. Like you don't get that subcortical tract information if you're not doing awake stimulation. And then the other thing about the SEG is that if your SEGs like ours are spread out like this, the benefit with the subdural grid is that it's like so close together, you get more like precise information and you get this larger area. Like if you put a grid, this area, yeah, there's the contacts are closer together, and so you maybe get more like precise topography information. So here's our case. These are the intraoperative pictures. I wanted to show you what exactly we did. We did awake mapping, and then we had ECOG to help us. We put depth electrodes here as well. This is trolar. This is post central sulcus. You can see that motor face, motor sensory. As you know, motor face is bilateral cortical representation. So you take it, you can get their facial motor back after a few weeks. They can gain that back, but of course, stay away from hand always, unless absolutely necessary. They'll get into hand territory. I wanted to also show you that. Yeah, so to orient you, also this is the temporal, this is the frontal. So after we've taken out these active areas, usually we just leave a depth electrode in and make sure everything is quiet before we stop our ECOG. Pathology was vococortical dysplasia. Oh yeah, so I wanted to tell you that cleaved massage, interesting anatomy usually it's closer to hand motor sensory, and just like right underneath that is like lots of white matter tracts to be careful of. That was the point of that. And then I've been doing this like post-operative tractography just to map out like what we actually did and how close we got. And you can see that we took out face motor sensory, but we were able to stay out of hand. We're really close to the corticospinal tract. Arcuofasciculus, SLF3 is not here, but it's just superficial arcuofasciculus. And we were able to achieve good outcome with this patient, angle 1A. Temporary face weakness as expected. She was able to get that back. He was able to get that back by follow-up, which is a few months later. And I wanted to pause here and just acknowledge Dr. Ocherman. He, of course, was the pioneer. Dr. Ocherman, he, of course, is the pioneer in helping us with our current method of how to map awake surgery. And it's really Dr. Ocherman that helped us with just like awake craniotomies, cortical stimulation, subcortical, and identifying these really important language regions. And of course, he was attending here at UW.
So I guess since he can't be on, I think there's two things he would say. One is he'd be very happy that you're being aggressive and resecting, because I'm not sure that that's for a dominant operculum. And then the second would be, I think he would want you to comment on the speech. You mentioned the face recovers, but on the dominant side, that's not really true, right? So I'm just curious what your approach is to dominant opercular resection.
So dominant operculum, we have to really be careful when we are awake mapping and stay away from any positive mapping areas. And then they have to be really able to talk to us and like really have to be really awake and accurate mapping and just to map out those areas and stay away. Cortical and subcortical in that entire area. So this is case number 2, a little bit different case, non-dominant temporal parietal epilepsy. So this is a different patient, female, right-handed, intractable epilepsy as well. Her semiology, blinking, pallor, oral automatisms, tingling, sounding very temporal lobe, and then she generalizes. EEG also pointing to right temporal. And this is a lesional case. You can see that she has these polymicrogyria in the temporal operculum and then also parietal operculum here. And then PET hypermetabolism localizing to there as well. Our MASc, right temporal, and just like a lot of dipoles clustered there. And then at this point, I think like everything is pointing very right temporal, and but we wanted to do an SEEG just to confirm. But I think this is one of those cases where it's easy to say is the right temporal, and can we just go ahead with the right temporal lobe? But we wanted to just cover our bases and do an SEEG and just confirm that, and where we can, if we can actually localize where the seizures are, so we can more accurately resect the seizure onset areas. And so we did SEEG, mostly covering the temporal, as you can see, as well as the perisylvian area, inferior frontal, and also the parietal opercular areas. And you can see from D, our interoictals mostly are the posterior, the posterior temporal and spreading to temporal pole. And then E, you can see that with stimulation, also like posterior temporal spread to a parietal, a little bit operculum, and then temporal pole. And then I also wanted to highlight on the coronal, like how deep our SEEG electrodes are. And you can see that, so this, the last one on this sagittal, the blue insular electrode, it's, these are actually the spreads, it's not on that, it should have been light red. But you can see that it does go into where the lesion is on the temporal side, operculum. And then, so semiological mimicry, this is a good case. So if you had perioral tingling, facial tingling, and that can be ipsilateral, contralateral, or bilateral. And so SEEG sometimes can be helpful in helping us localize. And S2 with strong bilateral representation. And then our intraoperative, to orient you, this is the temporal here. That's superior temporal gyre, superior temporal sulcus. And then this is S2. We put depth electrodes in these three areas. We kept the posterior depth electrode in, and then we proceeded to resect the posterior temporal, superior temporal gyres, middle temporal gyres, and then S2. And we were able to achieve no activity on our intraoperative ECOG. And then she also had very good outcomes, 1A angle 1A, and no deficits. And so just to summarize our two cases, I wanted just to emphasize that opercular epilepsies can be difficult semiologically, and it covers a large area like the operculum, inferior frontal, the parietal, and the temporal. And so it can really spread and be confusing sometimes in terms of the semiology, as you saw in the second case. Temporal, it can masquerade as temporal lobe epilepsy, it can masquerade as frontal epilepsies, and then also cardiac events, as you know, laryngeal respiratory diseases as well. And then anatomical consideration as well, mostly in case one, you saw that awake mapping was really important for us to be able to get into safe windows, as well as the vascular anatomy, retraction on the operculum, and then just irritation of these vessels going in as you get into deeper vessels, like the getting close to insula, you have perforators, and they can be really irritated post-operatively. You can get vasospasm to keep them at least normovolemic. We didn't talk about is like the ventral stream language, so like the Antoinette and the IFOF. We didn't have a case to cover that, but definitely and also a really eloquent area, particularly in the Lyman Insula when the two tracks meet. And this is also, of course, really dangerous vascular territory, as you know. So shifting gears, emerging techniques. I want to talk about the research that I've been involved in this year, and also like what the motivation is. So I think that some of these cases are very focal and localized in the operculum and eloquence. And so if we're able to really localize where these seizure networks are, we can help patients achieve seizure freedom. But I think this type of epilepsy, because it can be really complicated, there's a lot of workup involved. There's SEEG, there's like preoperative workup, and there's anatomy can be difficult, and vasculature, white matter tracks, mapping, eloquence. So sometimes it's underutilized, but I think if we are able to understand this anatomy, like with a deep understanding, if we can use the modern tools that we have, maybe we can approach these cases with better confidence and help more patients to achieve seizure freedom. And so that's kind of the motivation. And then I jump into this project, tractography-based post-op outcomes in opercular epilepsies. And this is a paper that we wrote recently on this topic. So as you probably have gathered from these two cases, it's distinct and it's underserved surgical challenge because of these reasons and extensive workup. And so I think we can learn from other neurosurgical disciplines. In glioma surgeries, we use tractography to help with surgical planning, and they have outcome data from that. Corticospinal tract and arcuate fasciculus, they have specific numbers like corticospinal tract 5 to 10 millimeters, higher risk of motor deficits, arcuate fasciculus, less than 5 millimeters, higher risk of aphasia. But in epilepsies, it's a little bit different in that there's not like a tumor or a lesion, and there's no edema, there's no distortion of tissue. And so I think that although we can extrapolate a bit, I think we need to do our own kind of validation and see if those tracks actually have post-operative meaning. And I wanted to look at that. So tractography used in preoperative planning and post-operative outcomes haven't really been looked at in epilepsy. So that's what I wanted to look at in this project. So I wanted to look at post-op transient and permanent neurological deficits, as well as seizure freedom outcome rates in this retrospective series that I'll share with you soon. And then also look at the distance that we can resect in relation to the proximity of the white matter tracts. I just focused on two for this study, cortical spinal tract and arcuate fasciculus, using tractography that I built on BrainLab. So we had 14 patients. All of the patients had SEEG guided frontal parietal or temporal opercular surgery, opercular resection for medically refractory epilepsy. And then I looked at several different variables, including cavity volume, opercular location, postoperative blood, whether there was a lesion or not, dominance. And then the most important thing I wanted to look at was the distance between cortical spinal tract and arcuate fasciculus. And then our outcome variables, as I showed you, is neurological deficit and seizure outcome score. Here are methods. So here's an example of how I measured the distance to the cortical spinal tract of two different patients. These are not related to the case one and case two. These are two separate patients. But essentially in the coronal plane, you can see the cortical spinal tract more clearly. And I just measured essentially like the coronal, the closest distance to the tract. And then we use standardized parameters that we extrapolated from tumor surgery, tumor surgery tractography numbers using probabilistic tractography. And then our outcome measures, we looked at angle score, and then we had a large range of follow-up for this 6 months to 3 years. And then we did Wilcoxon rank sum testing to look at association of tract distance and outcomes. And then we looked at logistic regression to predict clinical outcomes. So here are some baseline characteristics that we had. So most of our patients had no lesions. That's like 64%. As you know, lesional cases tend to do better seizure outcome. And then site of surgery, dominant or non-dominant, half or non-dominant. And then cavity of resection, most of our, this is blocking. Oh, it's not blocking on your side. Perfect. So most of our resections were small area resections because we're talking about like really small areas of surgery of epilepsy foci. And then also wanted to share with you, most of our patients were extratemporal actually, about 43% were temporal. Half had transient, half had no transient deficits. And then most of our patients had no permanent deficits, 85.7%. And then most of our patients did pretty well in terms of angle class. Most of our patients had angle 1 or 2. And I think that parallels like current literature on opercular surgeries. So they tend to have a lot of patients tend to have good seizure outcomes and no permanent deficits. And then here are some of our data. So these panels are showing you the association between the cortical spinal tract distance to the angle outcome score is the first panel here. The second panel here is looking at the arcuate fasciculus distance to our postoperative resection cavity. You can see that when we look at those that had good outcomes, angle 1 or 2, we call them good outcomes, their distance to the cortical spinal tract tend to be a larger distance compared to those that had poorer angle outcomes, 3 or 4. And we saw statistical significance here. And then in arcuate fasciculus, we saw a similar thing, but we had just a tendency, no significance, where the farther we were from the arcuate fasciculus, the better angle outcome they tend to have. And this, of course, is an indirect way to look at this. But also we looked at the more obvious outcome, which is neurological deficit. You would think that if you're closer to either of these tracks, you would do worse. But actually the findings were non-significant, although we saw a tendency. But also we only had 2 patients that had permanent deficit. So obviously the statistics is not as powerful due to the number. But it's good that we only had two patients with permanent deficits. And then our logistic regression, I looked at different variables here. And then here I looked at predictors of angle 1 outcomes. You can see that, as we already know, those patients with frontal epilepsies tend to do worse. This red line is 1 odds ratio no effect. So this is already information we know. Patients that had dominant epilepsies tend to do worse angle outcomes, also information we already know. Those with lesional epilepsies that you can see on imaging tend to do better, also things we already know. The last two is new information. Those that had their resection cavity that were farther away from the corticospinal tract tend to do better, odds ratio 1.15. And then those with same thing, distance that were farther away from arcuate fasciculus tend to do better. And out of all of these variables that I show you here, really the only strongest predictor was the corticospinal tract, even more than the other ones that has already been studied and known. So corticospinal tract, we found that as an independent, indirect predictor of seizure freedom. And we saw a p-value of 0.021. And so what does that mean? 1 millimeter increase confers 15% higher odds angle 1 outcome. With corticospinal tract more than 20 millimeters away, we saw 80% angle 1 probability, less than 10 millimeters, 10% angle 1 probability. And these numbers are very similar, but obviously different, similar to the tumor data. And so this maybe supports that tractography could be informative for us as we plan these eloquent surgeries and for counseling overall. But arcuate fasciculus, even though we saw the trend was not as significant as corticospinal tract, and the trend also parallels what's known in tumor surgery. I already said. But I think there's some very obvious limitations in this study. We didn't look at all the tracks. We didn't look at SLF. We didn't look at contribution of vasospasm, which can happen in these cases. We didn't look at lesion pathology. We also had a small sample size overall and a small sample of permanent deficit patients. And then also 3 months to 3 year follow-up, like 3-month angle 1 is not 3-year angle 1, but we just had that range, unfortunately a limitation. And so I think opercular epilepsy surgery is really challenging, both technically and conceptually, but I think we can use more tools available to us to maybe be able to improve our surgeries and improve our safety and reproducibility. I think there are many next steps that we can do. Larger cohort is the obvious one. Add other tracks is another one. Prospective design with like more standardized protocols, pre and post-op tractography. We can include other things. We can include MEG, BBM, intraoperative neuromonitoring data to help us get a better prediction. We can also compare with laser. Like we didn't look at any laser cases, but that's definitely it would be interesting because laser, as you know, there's a lot of edema associated with it after day 1. That could be an interesting route. And then, so these are all interesting next steps. So shifting a tiny bit.
Sorry, before you go ahead, because when Dr. Gonzalez-Martinez has presented this, he's often presented laser when he was there, laser ablations with the entire dominant insula with really not much language impact.
Yeah.
So do you think why would that be?
So I think laser, when we do laser, it's like a specific area of ablation. You grow it, right? Like as you increase the temperature, you increase the ablation, you grow it. And the actual lesion would be the area of deficit, but it's such a small lesion and there's so much edema that I don't know if this is true, but I'm just like speculating. Maybe the edema is helpful in that it kind of pushes away a lot of the associated adjacent areas. And so maybe, but then they have the smaller lesion, right, in the center core of where they're ablating. And so maybe that edema is helpful in eloquent areas.
But in that case, do you think there's eloquence within the insula itself, or can you really get away with a lot of insular proper?
There might not be, like, I know that there is just just underneath the insula, many fairly important tracks, but we've personally have had multiple laser insular cases, like insular cases where we lasered high eloquent areas, and none of them have had any bad outcomes. Like post-operatively, they just have like maybe a little bit of deficit, but it goes away after a week, and after like a week of DEX, decadron. So they tend to do really well too, the laser patients. And we like blast the insula and we make it like a huge, initially looking like a huge lesion, but it's mostly edema. And then after a while, it's just like a small lesion area. And they do really well as well. Dominant insula.
One more question. The insula is very important for autonomic control, and did you have some deficits, autonomic, or is this area insensitive to unilateral lesions? Or
So we didn't look at autonomic deficits in this, just like the very first study that we did, because we just wanted to look at very obvious cortical spinal, like motor and speech deficits as the initial. But I definitely think that as I kind of grow this project and increase like the variables involved, I think that we should look at all types of deficits for sure. But in this particular one, we didn't get into that for now. So the role for thalamic neuromodulation, I think this is super interesting. And I think it's really important also for cases that are refractory to surgery, not just in general neuromodulation, because we did have 15 or 20%, I forget the exact number, of patients that didn't do well after very targeted SEEG mapping and resection. Like we still had refractory patients. And so definitely a role for neuromodulation, even in opercular epilepsy. And so neuromodulation in thalamic epilepsy is really the only FDA approved area, as you know, is anterior nucleus for mesial temporal, mesial frontal temporal epilepsies. For opercular, it's not the same area. So I'm not sure that although we haven't tried, I'm not sure that anterior nucleus, just based on what we know, would be a good target for neuromodulation in opercular epilepsies. And then centromedian, we know that the cortical spread of the connection to the centromedian is really generalized and really widespread, which is why right now they're looking at targeting centromedian for generalized epilepsies. But of course, opercular epilepsy is in the name, like it's focal epilepsy to operculum. So I also don't know if centromedian would be a good target for opercular epilepsies. And then I just wanted to also put Nautilus trial here, because as we know, Nautilus trial, I think it's like 19 months now, or maybe 18 months. And they had some data that they presented at ASSFN. They had like 70% median reduction in seizure for generalized epilepsies with RNS to the centromedian. But again, I'm not sure that centromedian would be a good target for opercular, given that it's an open epilepsy. And then this is, we collaborated with like 5 different centers to write this paper on thalamic neuromodulation, just like discussing different targets in thalamic epilepsies, and then also how we do SEEGs and what recordings that they would expect to see, and also other targets. We talk about pulvinar, lateral pulvinar, which is not opercular, it's like occipital networks, and then medial pulvinar sometimes for people that have psychiatric comorbidities and that are anterior nucleus target patients. So I also include this image here, you can see, because this is from this paper that we put out. Essentially, I wanted to show you like our SEEG. I know like there's different ways to put the SEEG leads in for thalamic targets, but we tend to like to put it orthogonal. This one is anterior nucleus, and because we want to capture all the information we can, frontal operculum, the insula. You can imagine that these can be really difficult to get through like vessel windows, but with enough time and patience, you can get a good target to the anterior nucleus. And this one is a centromedian, similarly, temporal operculum, posterior insula capture, and then centromedian. We usually just use MP2H for centromedian. I'm not sure, I would be interested to see how Dr. Code is targeting. And then the F-gator for anterior nucleus. And then opercular epilepsy networks, we need to understand at the thalamic level really to be able to optimize our target selection, and especially those that 50% that had surgically refractory seizure reduction. And I also wanted to talk about closed loop thalamic neuromodulation. Can we, especially with the Nautilus data that will be done, I think, in 24 months, can we use that information that is captured from RNS and learn from that? And I think that might be a useful information for us as we go forward, looking at different thalamic targets that are potential that can help us with these refractory patients, surgically refractory patients. And then what about if with closed loop neuromodulation, the network changes over time, and can we actually complement that with surgery down the line in the future as we understand more about what targets to choose and how the networks are going to adapt with modulation with RNS or other closed loop methods. And here is a picture I wanted to show you of our centromedian DBS from this chapter that I helped to write with Dr. Machado. And I think that so in this chapter, I collaborated a lot with our DBS colleagues, DBS movement colleagues, because they are really the experts in DBS and had DBS for a long time in movement disorders. And so I think that collaboration is really important. And this is an image that we created for our epileptologists to be able to understand the anatomy and see what contacts they can use to target. Because I think sometimes that conversation about like where our leads are in surgical terms is harder to conceptualize for the epileptologist to help with our programming. What about future directions? So I was thinking about this, and I think that a prospective tractography guided protocol with outcome tracking with different variables, not just tractography of the tracks that we're interested in, but also of like BBM, of NEG, SEG data, interoperative data could be helpful with our looking at predicting outcomes. And then of course, collaborating with different centers, because this is not a huge volume of patients overall. And so definitely collaborating with different centers would give us more information. And then network analysis of opercular connectivity is really important, which we would be able to understand with more information from our SEG data, I think. So completely shifting gears into other non-epilepsy related interests. I wanted to also tell you about post-stroke neuromodulation. So this work is Dr. Andre Machado, who was my functional chair last year from a functional neurosurgery fellowship. So he looked at posterior fossa DBS in the dentate nucleus for post-stroke rehabilitation in those that had MCA stroke. And this is past like the initial 6 months of the stroke. So I think when he was a fellow in the clinic, he started this project from like rodents to now human. So I think that's like really inspiring to me. But so it like 3 years ago, it was the first human trial, first phase 1 human trial for posterior fossa DBS. And what they're targeting is the dentato-thalamocortical tract, and then the corresponding cortical pontine cerebellar tract for upper limb rehabilitation after stroke. And what they found was, this is like the main slide of their paper. There's a lot more in the paper, but I just wanted to summarize this quickly for you guys. Those that had only rehabilitation only, they had improvement in their Feeble-Meyer upper extremity score by about 3 points. And then those that had DBS of the dentate nucleus plus rehabilitation had another increase by 7 points Feeble-Meyer score. And then even when they shut off the dentate nucleus stimulation, they were able to preserve their improved mobility in their upper extremity. So that was an interesting paper for sure. And then, so that's hopeful for our patients that are post-stroke, is really what we're offering right now is only the Vistin VNS. And so it would be great to have other options to offer our patients. What exactly is my involvement? When I came in as fellow last year, Dr. Machado was kind of ramping up and scaling up his phase 2 trial. So this is his phase 1 trial. Phase 2 trial, I think he has 4 other centers that are going to help us with recruiting patients. But when I came on, we started seeing a lot more patients and just like ramping up our volume. And so I helped with just like standardizing how we're gonna target, like what images to use, and our overall workflow. And this is the posterior fossa, right? So you can imagine that it's a little bit different from the typical supratentorial DBS. Posterior fossa, it's a tighter area. The Lexel frame is flipped. People are prone. Here's a picture. The patients are prone and they're like the Lexel is flipped. And this is a zoom in. You can see that this area is really tight. The ET tube is like squished. There's a lot of just like mechanical issues with this, particularly if they have like a large shoulder and short neck and just like hard to get in. So anesthetic challenges for sure. And then when the O-arm comes in, also surgical access challenges. And then when you open the dura in the posterior fossa, you can imagine all the CSF comes out. And unfortunately for stereotaxy, that's not ideal. And so I was part of this, just kind of working through this. And then, so the question was, can we use something else? And I saw that Dr. Poe had a StarFix frame in your office yesterday. But so I said, maybe we can use a StarFix frameless system and avoid that entire like challenge of the anesthesia axis and like the axis of the surgeon. And so we looked at this, like using these phantoms, and just, I wanted to see if we can have an alternative. And of course, this is in vitro, there's no CSF loss, but with that in mind, the in vitro study, we were able to reach submillimetric targeting error. So that's similar to supratentorial targeting error that is acceptable to us. And I just looked at the vector, and we were able to write this up as the first time that frameless is used in the posterior process. Completely shifting gears again, HIFU. We do HIFU at Cleveland Clinic. We have about 50 cases per year, 2 to 4 patients per week. We currently are using VIM only as the target, but that's expanding to other Parkinson targets. PTT, I was talking to Dr. Poe about this yesterday. But I think that it really expands our patient populations that we can help with essential tremor or Parkinson's disease. And we're not doing bilateral as of a year and a half ago. It's FDA approved, you just have to wait 6 months. And so this is what it looks like. It's ideally you get a lesion in the VIM. You can see that well, but it's quite dark on my screen. But you want a lesion so that the tremor improvement stays permanent, because we can get to a point where they're improved, and if you stop, it will just come back in a few weeks. So getting a lesion is the ideal. And then this is 1 day after. You can see this giant edema surrounding the lesion site, but actually they do really well. Though this looks scary, like this is the dentatorubral-thalamic tract here on the good side, and here's our lesion. You can see right here, and there's a lot of edema just pushing against the capsule. But she was actually completely fine. She was like very elderly. These are very elderly patients, very frail. And incisionless, you just put the frame on, put the bladder on, put the water in, and they're home after the procedure. It's a day procedure. So it's very rewarding. And then we have some projects here that are unpublished. I wanted to share with you. We're looking at incorporating 7T. There's distortion issues with that, of course. We're looking at motion detection sleeve. We have this sleeve that you can measure motion from the finger tremor, the wrist tremor, the elbow tremor. So then as we're ablating, we can see how the improvement is going, because sometimes it's not obvious. Like if their finger stops tremoring, but their elbows are still going, you can kind of adjust your targeting based on that and just capture all the tremor. And then we're looking at clot liquefaction as well with LIFU, low intensity ultrasound. So currently I do the HIFU at Cleveland Clinic. That's me. This is a patient. This is our workstation. And then what about HIFU in epilepsy? So because I did HIFU last year on my functional side, and currently I'm doing epilepsy on the epilepsy side, they're two separate in Cleveland Clinic. There's two separate groups of people. And so I thought, what if we could incorporate HIFU in epilepsy? And so this patient is somebody who is complicated. He had VNS, right temporal lobectomy, SEEG at an outside place, outside center, out of state. And he came to us still having seizures. So we repeat this SEEG. And he has 2 periventricular nodules, one here, one here. And so we put SEEGs in both of them to capture seizure recordings, and they were coming from there. And so we decided to RF ablate these 2 nodules, and his seizures reduced by half. And this is someone who has a lot of seizures. I think it was like 60 per week or something, cut down to 30 by just ablating it with the SEEGs in. And that was really informative for us, because it's like so that's where its seizures are from. But we know that for sure. So then what if we did HIFU for those 2 periventricular nodules? And can we help this patient? Because we know this is where the seizures from. It's a very small area. And can we do that? And so we tried it. It's off label, but we did try it. We put on these MRI compatible EEGs for mapping. We didn't really get anything on that, but I thought it was fun. And then, but because it's so close to CSF, there's a heat sink from the CSF. So in HIFU, you want to be able to reach high enough temperatures to get the lesion. But we couldn't reach that high of a temperature, even with, it was like 41,000 joules that we use, which is like 4 times the normal. So we couldn't get that temperature. We couldn't get the temperatures high enough. Even though it was sub-lesional temperatures, he's seizure-free today, 1A. So we're quite happy with that. And he's about 1 year out from his HIFU. So I just have 2 more slides for objectives.
Sorry,
how am I doing?
did you see a lesion post-op?
No, we didn't. We couldn't get high enough temperatures to get lesion, but I think we reached enough that it kind of neuromodulated, or just like changed the architecture of the seizure network enough that he's seizure free. And so we've been like following him really carefully to wait for seizures to come back because of no lesion, but you still get, it's like, 13 months maybe from that. How's my time? Still some time.
Some questions.
Oh.
Go ahead. Don't finish your talk.
I just have 2 more slides on my just personal objectives that I wanted to share with you. Epilepsy surgery, as I told you in my talk, I have an interest in that, so I would like to continue to do epilepsy. Specific interest in SEG-guided, SEG-guided resections. Extratemporal epilepsies are interesting to me. I've seen many patients come back with temporal lobectomy still having seizures. So these are really underserved patients sometimes. Opercular insular epilepsies are challenging, but it's interesting to me. Thalamic neuromodulation techniques, as I said, is also the future, and we need to collaborate with neuromodulation experts to ideally help all patients that are more difficult and complex to help reduce their seizure burden. And I want to do that, all of this by collaborating with the current epilepsy team. Post-stroke neuromodulation, I want to partner with in developing a dedicated post-stroke recovery program using the current methods that we are using, VNS, as well as other methods, emerging methods like I told you, the dentate nucleus DBS, Machado is working on. And then movement disorder, I want to be able to complement the current movement disorder team by bringing in HIFU, and in the future, maybe LIFU for other indications. And then psychiatric neurosurgery, I would be interested in explore. I don't have that experience, but I would be interested in explore and grow a psychiatric program in collaboration with psychiatric colleagues, beginning with VNS for depression, DBS for OCD, expanding to MR guided LIFU for other things like depression, PTSD. It's an emerging field, which I don't know much about, but I would be eager to learn about it. And then pain neurosurgery, I would like to build on the current pain program, collaborating with current colleagues and expand my expertise across the pain program. And then lastly, just the 3 academic objectives I have. I want to develop a more comprehensive pre-op tractography-based framework that maps out where the epileptogenic networks are and where critical matter tracks are in extratemporal epilepsy, and where are the safe areas to go and where are the hot zones that we should avoid. And then I want to build a multimodal framework, including different imaging, functional biomarkers to include tractography, MEG, VBM, intra-op, monitoring data, SEG data, and others that help us predict seizure freedom and outcomes. And then lastly, as a more long-term goal, to help establish evidence-based guidelines in surgical decision-making to help extratemporal epilepsies. And I'll do this by prospectively correlating white matter tract patterns, long-term seizure outcomes, and functional and quality of life outcomes. So what I hope to bring to UW, focused clinical and research program in epilepsy and functional imaging, and complementary expertise in functional neurosurgery, and then hopefully make complex surgery safer and more predictable and more accessible to more people. And so I just want to thank my mentors, Dr. Bill Bingaman, especially. He was a great mentor, teacher, great person overall, and excellent surgeon. I learned everything in epilepsy from him. And then Dr. Machado, he's our head of functional neurosurgery, also an amazing person, an amazing surgeon. And then the rest of the epilepsy team, the rest of the functional team, and then our HIFU team, which are the neuroradiologists that we partner with to do HIFU. And here's the pictures of my fellowship. Thank you so much.
Questions?
Last question, changing gears a little bit, but related to your DBS work. What is your understanding of the state of the art of deep brain stimulation for long-term coma, which is an issue that we've seen kind of pop up a little bit. I know there's one of Dr. Shaker's colleagues in Croatia is doing some of this work, and others, but you know, there's some heralded cases of amazing outcomes and some not, but I'm just wondering what the state of the art is with that.
I honestly don't know about coma targeting. That's really interesting though. And do you know what they target for coma?
CMPA.
I'm not sure the answer, but it's definitely interesting to look into.
Just a different avenue of patient referrals instead of psychiatry, which is a very difficult nut to crack at UW. It's more of like a rehab, you know, kind of chronic long-term care type places, you know, obviously through stroke and trauma and things like that.
Ali Razai started that at Cleveland Clinic, but then when he disappeared, it disappeared. Yeah, I'd be interested in the targets.
Yeah, no, that would be interesting for sure. I honestly, I'm
Massive
not sure.
or Machado, and we don't know what they targeted.
Yeah, it's, I mean, I haven't tried for like 10 years. There was somebody in rehab who was interested and then she left. And since then,
Jeff, have you?
No, there's a few trials out there, either, I don't know who was doing fornix and somebody else doing particular. Oh, I mean,
I think they were missing CM in getting particular, but
but yeah, right, so so yeah, there's a Croatia, and then there's I think it's a consortium run out of Stanford that has an NIH grant for that. But I haven't heard much.
what's that?
You said they're targeting.
Yeah, they were targeting CM, which is vague, right?
Yeah, it's just like so widespread and
Yeah.
like everywhere is.
You take some genetic information out of these foci that they remove.
No, so there's another group within our group that's doing that, but I didn't incorporate it into our protocol. But I think down the line, that could be a variable to be added to help with predicting, because I think lesion
Yeah, that's
pathology
crazy.
is for sure a variable that will change the outcome.
Yes.
I think down the line, that could be for sure added to our framework.
What about rheumatology? You know, the whole chronic RA and VNS, is that?
That was actually at our ASSFN. Somebody had a VNS or RA talk. Yeah, I mean, we're not doing it at Cleveland Clinic yet, but I think neuromodulating like autoimmune, I think it like suppresses the immune reaction. I don't know too much about it, but I know that some people are putting VNS for rheumatoid arthritis based on what I heard at ASSFN.
I'm going to a meeting this weekend and one of the sponsors is Set Point Medical, which is the FDA approved device, right, Andrew? And
Yeah.
I know Andrew's been talking to them a little bit, but I don't know, is it something we should pursue?
We have a wait list of 32 patients.
Wow.
We're getting it
So that's a
set up.
yes?
Yeah, I mean, it's already, I'm meeting with them Thursday to finalize workflow
Well,
And that's all gonna happen here.
It's gonna happen at Northwest. The rheumatology group there's really big.
what's the?
The VNS.
Fewer tender and swollen joints.
Okay, so that's the end point.
Oh.
That was the endpoint of the trial.
It doesn't change any of the parameters, the measurable parameters.
It drops your TNF alpha levels like 50%.
Really?
Or that's what they showed in the animal studies.
Wow.
I don't know if they measured it.
I don't know if you understand, I don't understand the mechanism, but there's all sorts of anti-inflammatory.
Yeah.
Across a wide variety of diseases.
It's
only a few minutes of stimulation per 24
It's a
hours.
minute a day.
Yeah.
It's like,
It's
if you
not
didn't see the trial
continuous.
results, you'd be like, this makes.
And these are people that failed biologicals.
Yeah, the
Yeah.
trial was for people who.
Intractable.
Yeah.
Wow.
75% were off biologics at the end of 1 year.
Although again, it's like, it's a drug that doesn't work. How hard is it to come off?
Yeah, right.
Pure refractory.
Yeah, I mean, it's been miraculous for that population.
Yeah.
90%.
We just started a trial for MS too, relapsing remitting MS. So we implanted one patient, I got a second one scheduled.
That's just,
Matt, do you have
for
experience
trials,
with?
though. That's a trial
you
stage,
guys
not-
do?
No, I don't know if there's any, sometimes the pediatric world is a little slow to.
Yeah.
It'd be interesting to think about what indications in peds may make sense, but I'm sure they're out there. Stimulate everything.
Here's what ails you. I mean, it's like.
Ehlers-Danlos.
Yeah.
That's.
Shunt failure.
For shunts.
but just to plug,
That's the
a
answer.
plug internally, you know, if there was capacity and volume, you know, the Harbor View new outpatient ORs would be ideal for it. I know you're talking to Mike about it a bit, and what we found is that the turnover time and the case times have done what we hoped they would do, which is much shorter, much faster. And, you know, it's like an ideal environment for outpatient quickie stuff like that, you know, so.
Yeah, we were kind of thinking Vivistim at Harborview because stroke is there. And then since rheumatology, they're in the same building as the outpatient surgery center there.
I'm hoping to get it to a point where it doesn't matter where the patient's seen, you can just at least do the surgery there.
absolutely.
And they can follow up wherever you want them to follow up, you know, and it's pre-op, post-op, all that stuff, you know. But sometimes the bottleneck is just getting them scheduled, you know.
Yeah.